McGregor, Dr. Albiges, Dr. Roth.
Great. So one of the very popular sessions that we keep repeating every year is the updates that happen both clinically and translation in kidney cancer. And for that, we got expert that actually did the work here. We're gonna go through first line, second line, and metastatic RC, adjuvant, non-clear cell, and then we're gonna focus on novel target, both from immunology perspective and non-immunology. Okay, I'm going to start first by Dr. Powles, who finished his slides after his run. Thank you, Tom, for providing slides. Tom's going to talk about first-line systemic therapies and not.
Thanks, as always, for inviting me. I'm going to get through some slides if I can. I think most of what I'm going to say is broadly true. I'm not going to make any comments about the American independence this year because of feedback I got from what was basically correct comments last year. I still think it was a mistake, as I said before. I think I have a number of conflicts of interest. We've reached a plateau in the frontline. This is the reality. We've reached a plateau in frontline renal cancer, including clear cell disease. I think probably papillary renal cancer is moving more quickly. I think that's a fantastic thing. We've done exceptionally well. When I started treating this disease, survival was about 12 months. Survival is more like 5 years now. And that's a great achievement. But we also need to recognize that we have two main targets. VEGF-targeted therapies, which basically are essentially all the same, and immune checkpoint inhibitions, PD-1 therapy and CTLA-4, and the PD-1 therapies also are more similar than different. That means we've got two big groups of drugs. If probably fits in more predominantly with the VEGF-targeted therapies, and whether that's associated with improved survival, we don't know yet, and there are trials looking at that. There is controversy, and this is perhaps one of the bigger issues around the IMDC classification. The CheckMate 214 study made us use it as a predictive biomarker to predict resistance to ipi/nivo. So the good risk patients' initial hazard ratio was 1.6, and therefore the FDA said it predicted resistance to ipi/nivo, and therefore we were not allowed to give ipi/nivo to good risk patients. That became a global phenomena. If you look at the detail of the clinical trial, it was an ITT population. It was actually positive in the ITT population, which included that good risk population. As time has gone by, the landscape has changed. But the reality of the IMDC classification is a huge oversimplification. It does not represent the biology of the disease. In purple and red, you can see angiogenic signatures, but also in blue, in orange, and in green. You can see immune signatures, and you can see immune signatures in the good risk population. The IMDC classification changes with time. You can move from good risk to poor risk, and doesn't represent the biology of the disease. And dare I say it, it's actually now holding us back. And that's a problem, because if we have reached a plateau and we want to move forward, we can't be held back by things which are not helping anymore. So let's look at this. In the good risk population, the favorable risk population with ipi/nivo, the curve is on the right-hand side. You can now see a hazard ratio less than 1. You can see the curves crossing. Now, I'm not suggesting it's better. But if you compare that, for example, with Axin Pembro in the good risk population, the curves look very similar. So when people say, oh, you have to give VEGF TKI IO to good risk patients, and you can't give ipi/nivo to good risk patients, I would push back now fairly strongly. I think we should just drop the classification altogether to pick patient for therapy, in my opinion. That should be the answer. We should move on from this discussion, and it will help us. Let's take it a different way. What about in the adjuvant setting? In the adjuvant setting, we know immune therapy works from a survival perspective. We know VEGF-targeted therapy doesn't work. Many patients in the adjuvant setting have favorable risk-type disease. So that makes no sense either. The evidence now is pushing strongly against the IMDC classification. And indeed, when I put a question survey out, I don't know who answered the survey, but I think the answer is we are beginning to lose our patients from a predictive perspective in the community. The ESMO guidelines include ipi/nivo in that classification in the favorable risk group with 1C, not 1A evidence, 1C, same as sunitinib, same as tivozanib. So I think we are moving forwards. And indeed, where we asked people what they think, actually ipi-nivo in this population, 75 versus 25%. I think there are more, as I said before, I think we should drop the classification altogether. I still, in terms of, I'm not going to talk about which is the best regime. There's been no data in the last 12 months to say which is the best regime. Pick one, use it well. It's much more important how you give the therapy, whether you have appropriate nursing support, whether the patients are properly consented and informed. That's much more important than the differences between Ax and Pembro and Cabo-Nivo. I feel pretty strongly about that. Yes, of course, I can find criticisms of the ipi-nivo data. The adjuvant data showed ipi-nivo wasn't better than placebo. We don't know the results of the 8x8 trial. I can say negative things about ipi-nivo. I can also say positive things if I choose to. Here we have the COSMIC 313 study, the addition of cabozantinib to ipi-nivo. And in the poorest population, it doesn't seem the addition of VEGF-targeted therapy makes any difference. This doesn't mean the VEGF-targeted therapy doesn't work in those patients with the most aggressive disease. It just means the IMDC classification is not LP us. Again, another example of it holding us back. I think I'm now going to talk about 4 or 5 scenarios which I think are relevant from a clinical perspective. The first is, what do we do post-adjuvant pembro? And the answer is, we don't know. I don't think we should be re-challenging patients routinely based off the result of the CONTACT-3 study showing that sequencing atezolizumab after pembrolizumab, after immune therapy, was not effective. I think the community feels that there should be a gap before you re-challenge, and the debate is, should that gap be 6 months or 12 months? It looks like we don't know the answer to that question. I have to say, from a biological perspective, it's hard to come up with a strong rationale why initial immune checkpoint inhibition would fail and then would then suddenly work when you combine it with VEGF-targeted therapy. Mike Atkins is in the audience. I'm sure he would very eloquently describe we haven't shown synergy between VEGF-targeted therapy and immune checkpoint inhibition. I think it's better at getting initial control of disease, but the tail on those curves do not stay apart, and therefore I'm not sure the synergy is there. Additivity, perhaps. And then the other issue, no matter how hard I look at the data, and no matter which data set I look at, I cannot show that Cabo is better in bone metastasis. Well, I challenge you to go home tonight and tweet and tell me I'm wrong. I'd be very happy to take part in that discussion. I think the discussion comes back from those bone scans in prostate cancer that were fabulous. But the reality is that has become a commercial discussion. I don't think it's a scientific discussion. I'd be very happy to be shown the data proving I'm wrong. I think it's also fair to say that ipi-nivo is not uniquely active in sarcomatoid tumors. I think it has the most robust data. It's the only one with the central review, and it has the longest follow-up. But actually the the VEGF-TKI PD-1 data also looks good in this group. That doesn't mean you can't give ipi-nivo. Fill your boots if that's what you want to do. But it would be wrong to say it's the only one with data in this space. I hear that from time to time in meetings I go to as well. The other issue which I think is incredibly important for our patients is not which regime we pick or what does the IMDC classification tell us. It's much more how long should we give these therapies for. VEGF-targeted therapy doesn't seem to be curing patients. Going on forever doesn't make sense, but that's what we're doing. Immune checkpoint inhibition, we're stopping at 2 years. I understand the rationale for that, but the fact that it takes that period for the Earth to circumvent the sun twice is not a strong scientific rationale. Actually, it probably makes more sense to keep going with the immune checkpoint inhibition rather than the VEGF-TKI, if you have my opinion. And indeed, the tail on the curve with ipi-nivo might actually be associated with the prolonged nivolumab allowed in the trial compared to the cessation of pembrolizumab at 2 years. Hypothesis generating, but not totally unreasonable. And indeed, when I ask our friends and colleagues around the world, no one really knows the answer to this question. I don't know the answer to the question. I think it's a very important question. VEGF treatment breaks, we all do them. We've done 2 studies with enforced treatment breaks. The first was the STAR study with sunitinib or pazopanib, where you could stop after essentially 6 months, stop therapy, and then restart at progression. No difference in overall survival. The only one was the really nice Italian study in the era of VEGF-TKI-IO, with many caveats to this trial. But I do draw your attention to the progression-free survival curve. They stopped at 6 months, median progression-free survival only 4 months. If after 6 months of therapy on combination treatment, you say to your patient, you can stop if you like, but there's a 50% chance you'll have progression within 4 months, I don't think patients will want to stop. That suggests to us that intermittent therapy, while we're all pursuing it, is probably not safe, in my opinion, in the first year. If you look at the detail of quality of life data, and I haven't got time to talk to you about it today, one of the key drivers for quality of life is progression. Patients' quality of life drops when their cancers progress. So it's not all about tolerability. It's about cancer control from a quality of life perspective as well. Those two there's Shakespeare and Nelson from England. There's huge confusion between England and the rest of the United Kingdom. This is English data, and this is widespread access to immune checkpoint inhibition. So we have a healthcare system where you can be taken to hospital and it's paid by the NHS, by the government. You get free drugs, you get free food. There's no reason why you wouldn't want to have immune therapy. But we still show that about 40% of patients where it's free at the point of delivery, you can even get taken to hospital if you choose to. 40% of patients who are progressing not getting immune therapy in a robust healthcare environment. So those people who say, all patients should get immune therapy eventually, I don't think that's right. And that's quite an important issue. It has implications in the adjuvant setting, but it also tells us that we should be giving our best drugs first. And I think that is relevant, and perhaps that is a good reason for giving immune checkpoint inhibition for favorable risk patients initially. And indeed, I believe the adjuvant pembro data supports that too. There are a number of trials going on. I'm picking one, the CARE study from Europe, looking at VEGF-TKI-IO versus Ipi-Nivo in PD-L1 positive patients. There are other studies also looking at refining treatment. But as I said before, we have to some extent reached a plateau. So my final thoughts. In direct comparison to randomized trials has run its course. I haven't talked about any comparisons. I haven't talked about tails in the curve. I don't think it's helpful. It's become a commercial decision. All 4 regimes look very attractive. I'm very keen we move away from IMDC altogether. The duration of therapy is undefined. I'm keen we answer that question. Treatment after adjuvant therapy needs urgent data, particularly about this time of re-challenge. Prolonged treatment breaks in the first year is associated with accelerated progression and should be avoided, in my opinion. There aren't a lot of practice-changing randomized trials out there at the moment. I think we need to focus our attention on the development of phase 1 and phase 2 new therapies to reach the next plateau in kidney cancer in the next 5 or 10 years. May take your attention. With Bowen.
Thank you, Thal. I know how much you love the IMDC now and all the Twitter saying. So, Bob, I know we're 2 minutes late, but go ahead.
All right, so I'm going to give a kind of a snapshot for subsequent line treatment for advanced disease. And so what I've done in the last couple of years is really kind of giving you an update about what's on the radar screen since last year's meeting, given the time limits and the large profile here. We have different talks. And so these are just the topics that I think were relevant since our last meeting in 2024. And I won't read them, but we'll review some of the updates. So many critiques of NCCN guidelines, obviously, but it does have huge impact on patient use and access to medications in the United States. And so this is a summary of the subsequent guidelines that was just posted last week for your reference, highlighting the recommendations for 2025. I won't review these in detail, and I apologize for the small writing on the slide. But basically, for IO therapy naive patients, there's been phase 3 trials and high level of evidence for an FDA approval for many single agents after. However, that group really is no longer relevant based on what you've heard with Tom's talk. And so the box up below is the prior IO therapy, and you can see that there really is a lack of high-level evidence for how to manage patients who have progressed on IO therapy. For the most part, compared to 2024, we see tivozanib moving towards the left and belzutifan moving towards the left, and TKI plus IOs moving to the right of the chart. Now, one of the reasons for that was because probably the most impactful study that was reported last year and then published in The Lancet was the CONTACT-3 trial that looked at subsequent line IO therapy combined with cabo to cabo alone, showing absolutely no benefit in PFS, response, or survival, and more toxicity with the combination. So that kind of dealt a partial death blow to subsequent line therapy and IO. However, there are remaining questions in terms of that trial. I think we all feel that PD-L1 inhibitors or atezolizumab not as active as PD-1 inhibitors. The population of the trial was comprised primarily of patients on the old paradigm with had TKI, then IO, and then came back. So I think they're somewhat biased towards response to a TKI. And so I think the next trial will help to further define whether there's a role for immediate use of a TKI-IO combination following IO therapy. And this is the TiNivo-2 trial, which did complete enrollment, eagerly awaiting the results of the study. I think the benefit of this is that tivozanib is a very well-tolerated TKI, so would combine better with IO therapy. And also nivolumab is a PD-1 inhibitor. I think I have that, sorry for the typo. And so I think that we're getting around the PD-L1 aspect of the weakness or the criticism of the CONTACT-3 trial. So this study should be on your radar scope to hopefully get some results and further information in the near future. Now, as far as novel TKIs, I mean, I think the one that was reported this year that we should be aware of that's in development is zanzalintinib, which Monty Powles has presented at earlier meeting this year. It is very similar to cabozantinib, has a shorter half-life, seems to have a high level of activity based on the study that he reported. And for those of us who have used a lot of cabozantinib, we know that this is not a well-tolerated drug in the second-line therapy. And my own experience really has a lot of skin toxicity that and diarrhea that interferes with quality of life of patients. So this is proposed at least to be cabozantinib with a better tolerability profile, particularly less skin toxicity. So this is moved forward in combinations, and we'll see how it looks ultimately. But I think it's the one TKI that's novel that I think we should be aware of in further development. Now, the headline news, obviously, this year was the HIF inhibitors, right? And so this is the LITESPARK-005 trial that looked at pretty heavily pretreated patients, comparing to my favorite comparison arm, which is everolimus, obviously. And this is a study that Laurence and Toni led that resulted in approval for belzutifan and a novel drug that's now in our hand for patient use based on this study here. I just highlighted the population on the right from the patient characteristics to make note of the fact that for the most part, these were really pretty heavily pretreated patients. But despite that, there was clear activity for belzutifan in this setting. Now, I mean, again, a couple different caveats. I think we all saw this curve and noted the fact that the medians were the same as everolimus, but the fact that there were more durable responses in belzutifan was the take-home message. As well, response rate was 22%, which definitely, to me, indicates clear activity, a trend in survival. We're waiting for the final survival data. And a favorable toxicity profile, at least in the trials, that avoids many of the toxicities we see with the TKIs, particularly including hypertension and diarrhea. I think we're all now becoming used to giving this drug outside of a trial and managing the anemia, and also becoming more aware of the hypoxia, which is the other the kind of signal toxicity associated with this compound and how to manage it. So I think, the challenge with this is, where does it go, right? When I'm talking to patients about this, in terms of this is, another line of therapy that you're available, and you speak to a 25% response rate and a median PFS of 4 months, it's definitely not the home run that the patients are looking for. So I think that the directions really are, where does it best fit? Does it fit better in early line therapy? It is being studied in first line therapy and in the adjuvant study. And can it be combined with other drugs to make a better picture for our patients? So that is kind of the direction that's being taken. And this is a large phase 3 trial, the 011 trial, that looks at the combination of belzutifan with my favorite TKI, lenvatinib, compared to cabozantinib. And I think this will be a key trial to start looking at belzutifan in combination and moving it more up front. Now, the other thing is that, the other, really that area of interest is exploring novel HIF inhibitors, and there are a number of them that are out there. This was one that we were involved with at MSK. Ritesh Katisha was our PI, but this one kind of fell flat. This was a Novartis HIF inhibitor that was studied in this phase 1b trial, and from what I understand, they stopped the program based on a low response rate, lack of efficacy. So, one of the questions for the group really is, are all HIF inhibitors the same? Are they, are they going to be better, or are they going to be worse than belzutifan, which is really our standard model now for HIF inhibitors? I will say that in terms of the other studies that are really on our radar screen in terms of subsequent therapy that I think are novel and hopefully will be the future, are some of the novel cellular therapies that we have. And this study here was kind of leading the way, published by Monty Powell in Cancer Discovery, that did show some response rates to the CAR T program. I think, obviously this probably is going to get touched on later in the program, but the issue here is really kind of, is this a broad strategy that can be offered to many patients? Is the response rate worth the toxicity? And I think it's kind of just in its infancy. It really needs to be developed further. In my last 3 slides, I think I'm going to make the time here. So the new frontier, as Tom mentioned, is in terms of sequencing therapy after adjuvant pembrolizumab. Thanks to the wonderful work that Toni did and Tom did in terms of with the Merck group, in terms of the study for pembrolizumab and adjuvant therapy, which provides us with new option for our patients, but again, new challenges. And so this was modified from an ASCO educational series that I found was really wonderful for your reference by Dr. Wei Chen from University of California at San Diego, highlighting that this is kind of the new frontier now for sequencing therapy. There has been and back to Tom's point, what is the best way to manage these patients? This was a paradigm that was proposed by Dr. Bourlan in the ASCO Daily News about subsequent therapy based on time from adjuvant therapy. And I think it's a good attempt, but obviously we really don't have any information in that to define what is the best treatment options for our patients as they relapse on adjuvant pembro. As you know from the data and from our editorial, Martin Voss and my editorial in New England Journal of Medicine, about a third of patients will relapse following adjuvant pembrolizumab in that trial. So I think I pooled our group at Sloan Kettering. We got a fairly large group now of kidney cancer experts with Martin Boss, Marie Carlo, Neil Shah, and Ritesh Katisha to kind of start thinking about factors that would influence our subsequent therapy. And I think here's a few of them. Really, it's the response to adjuvant therapy, the time to relapse, the so-called IO sensitivity. Others are clinical features. What was the number of sites? Is it amenable to localized therapy? What's the location of the relapse? Obviously, is it in the liver or in an area that can be easily excised? Is it associated with symptoms? What's the histology? Do these patients have sarcomatoid features and are relapsing or progressing, or some other sort of histology? Also, what's been the tolerability of adjuvant pembrolizumab, and were they able to complete the treatment? And of course, the patient's comorbidities, and obviously a major factor is patient preference and the patient decision in terms of moving forward. And I think the other thing is, can we identify biomarkers to predict recurrence? And I think the keynote adjuvant study really would serve as a rich reserve to see if we can identify biomarkers that predict for recurrence or progression on pembrolizumab. So I think these are a lot of the different factors that we really have no data. This is also a slide that I modified from Dr. Yue Chen from the ASCO Educational. And in terms of this is kind of a paradigm that's been proposed. So we refer to IO, but it's really all ipi-nivo, right? There isn't another IO we're talking about here. And so I think in that setting, the proposal has been a TKI as a standard of care or a clinical trial. We now have belzutifan also, which is probably in my mind be a third line in that particular path. For IO TKI, again, it's TKI as a standard of care clinical trial. Can we move belzutifan up there? Some of the patients on Laurence and Toni's trial received second-line therapy with belzutifan, and so I think that also is a possibility to talk to patients. And then the new frontier with adjuvant pembro, where we really don't have any information in terms of what's the optimal therapy for those patients. And I think that's really where we need to look at retrospective studies and perhaps clinical trial. And so this is just my summary here, and I don't think I'll necessarily read that just to keep on the timeline, but basically that we really don't have any high-level evidence of a benefit for one treatment over another in subsequent therapy for patients who have had IO and first-line. Cabozantinib is kind of the de facto standard, and I think we really need to focus on the group of patients who are relapsing from pembrolizumab, since that's really kind of where we are today. And with that, I'll thank you all for your attention. Turn this back to Toni.
Thank you, Bob. We're a bit behind. We're a bit behind when you have the first two dots in metastatic disease reference, and probably half of it adjuvant therapy. I think that deserves its own adjuvant therapy. Bob was Dr. McGregor, my colleague at Dana-Farber.
Yeah, spoiler alert, you already heard a lot of this stuff already talking about. So I think it's great that we actually have a talk about adjuvant therapy at this point in time after like decades of trials where we've been having disappointing results. Now we actually have seen some differences. And I'm going to really be highlighting the positive things that have come out in the past year. We did see data that 6 months of adjuvant nivolumab did not improve disease-free survival versus 6 months of placebo. We had the excellent publication of PROSPER data. But I think the most practice-changing data was the overall survival data from KEYNOTE-564. So everyone in this room is now well aware of, just from today, yesterday, and everything else. KEYNOTE-564 was a trial that looked at the role of adjuvant pembrolizumab in clear cell renal cell carcinoma. Patients were randomized to get pembrolizumab for 1 year or placebo. And I do want to just highlight the eligibility criteria, because right now, as we think about the role of immunotherapy in the clinic, we are really looking at clinical factors. We don't have validated blood tests or MRD assays that we can use. So in terms of who was eligible for the trial, again, this is going to be T2 grade 4 or sarcomatoid features, T3 any grade, T4 any grade or node positive, and in the M1 NED group, which is those patients who had nephrectomy and they had metastatectomy, they had to be within at the same time or within a year, right? So this is not someone who had nephrectomy and then 3 years later had a single lung net. So this is that high risk M1 AD group. And so Toni presented data at ASCO this year, something published in the journal, just looking at extended follow-up. And so what we see with extended follow-up is that improvement in DFS is maintained, hazard ratio of 0.72. And we still, look, now we have out to 48 months with that continued nice separation of the curves. Even though we stopped the immunotherapy at that 1 year, it's not like suddenly the curves sort of collapse upon themselves. So it's just that there is a sort of maintained DFS benefit. And that translated into an improvement in overall survival. This is the first time we've seen this in an adjuvant trial in kidney cancer, hazard ratio of 0.62. And if you look at that 48-month, there's about a 5% absolute improvement in overall survival. So I think this is sort of a landmark change that now we have an improvement in overall survival with immunotherapy. Although the question is this influenced by what it had received in a second line therapy, right? So DFS is not going to be influenced by what patients get in the future, but we start looking at overall survival. Could we potentially salvage patients who relapse with immunotherapy and do just as well? And so we have some data on the subsequent therapies. And I think it's always challenging when you look at these subsequent therapies of like, what's the denominator and what are you looking at? So I think the key point is not all patients who relapse actually maybe needed systemic therapy. Some patients could be treated with a surgical resection or radiation. But if you do look at those patients who did get some sort of systemic therapy, which is 145 patients in a placebo arm, you can see that 70% of these patients got immunotherapy. So not 100%, but a very strong number. And I think that this is sort of interesting data. I think that we look at this, but ultimately the fact that we have an overall survival benefit really maintains that this should be an option for patients who meet the criteria for Keynote 564. And we should be discussing this with our patients. Patient, after discussion of the risks and benefits, may not want to do it, but I think it is very, very compelling data. When we look at the toxicity, there's really no new toxicity signals with extended follow-up. I do think that the toxicity of adjuvant immunotherapy is a little bit different when we start thinking about this versus in the metastatic setting, because in the setting, patients may be cured. And while, yes, they may be taking Synthroid every day for the rest of their life, it's a big deal. There are those very rare but real side effects, such as, adrenal insufficiency or diabetes, which if the patient is in that 1% and they get that can have huge impacts on their life. So I do, educate patients. That doesn't show up in these different tornado plots, but I think it's something we always have to think about that risk of those rare but potentially life-altering toxicities. But ultimately, I think the question is, as sort of alluded to yesterday, is, who really needs adjuvant therapy? That by very definition, adjuvant therapy, we're over-treating patients, right? We're treating patients with, hey, you may be cured already. We just want to see if we can improve those odds. So the real question is, is this therapy going to work? And do they even need the therapy, right? So this is adapted from David, this sort of how do we think about adjuvant therapy? So is there residual disease that needs to be treated? And if there is residual disease, is that tumor capable of responding to therapy? Or is the host even capable of responding to that therapy, right? So we need all these things together. You need to have this trifecta. And if you have that trifecta, then the adjuvant therapy is going to make sense. I think we need to start thinking about what can we do to help answer some of these questions. And I think there was some really exciting data in the past year for maybe some novel ways to think about presence of residual disease. And that was with KIM-1. So Vincent Xu with our group has been working on this for years. And we finally saw some really exciting data this year. So this was the emotion looking at atezolizumab versus placebo, a negative trial, and Laurence presented data that, KIM-1 seemed to be prognostic, right? So if a patient was KIM-1 low, they had a better outcome if they were KIM-1 high, and it seemed to be predictive, right? So there's reversal of the hazard ratio. So in those who were KIM-1 high, that patients who got atezolizumab did better than those who got placebo, and there was no difference in that KIM-1 low subgroup. So it suggests that not only is this something that can maybe be prognostic, but maybe it can be predictive, and we've actually seen this in other trials. So Vincent published analysis from the ASSURE trials, and the HighCAN one was associated with worse DFS and OS in all arms. And then we saw analysis from Checkmate 914 Part A that was Nivo-Ipi versus placebo. The HighCAN one was associated with worse DFS, but there was also a potential benefit from adjuvant Ipi-Nivo. So I think that KIM1 is something we really need to be thinking about and looking at in current guidelines, future trials. Like, what is its role? I think, as Vince alluded to in his great discussion at ASCO, we need to know what cutoff we're going to use. Every assay is a little bit different, but I think there's a lot of hope there. And then finally, I think we need to say, well, is a host-capable respondent therapy tumor-capable respondent therapy? How do we do that? And so I think there's some thoughts that maybe we can add more drug, attack different pathways, maybe adding things together would cause these hopefully some synergistic effects. So this is the LightSpark 022, which we heard about a little bit yesterday. This is completed accrual. So this is the exact same eligibility criteria Keynote 564, except the M1 NAD group is out to 2 years. And so patients were randomized to Pembro for a year with or without belzutifan for that time frame. And so I think this trial is completed accrual, and we look forward to seeing results. This is a large trial over 600 patients. And Toni talked about yesterday about B940. So there was some really exciting data with melanoma with Pembro with or without the vaccine. Hazard ratio 0.51 after the analysis at ASCO this year. And so that's the basis for the trial in kidney cancer, looking at patients with clear cell or papillary. So that's a key difference. The other key difference here is that the T3 had to be grade 3 or 4. So the T3 low grade are not included in this trial. And patients randomized 1-to-1 with pembrolizumab with or without B940, which I think will be really interesting. And then finally, we have an alliance trial, STRIKE, which should be opening later this year. The idea of can a short course of VEGF TKI with immunotherapy improve outcomes? And so patients will be randomized to pembrolizumab for a year with about 6 months of tivozanib, and the dose is still in development using the exact same eligibility criteria as the Keynote 564. So I'm the only one to finish a minute early, but pembrolizumab has a role in the treatment of clear cell renal cell carcinoma with improvement overall survival. We do need better biomarkers like the right pace for treatment. I think KIM1 is intriguing. And then I think ongoing trials are going to look to build upon the sex, adding belzutifan, maybe tivozanib, mRNA vaccines, and hopefully we're going to continue to have sessions on adjuvant therapy where after decades of negative trials, we say, hey, we have a new standard. And so thank you to you, Becky.
The McGregor will receive a thought ball for finishing a minute earlier. So now enough of first-line clear cell or adjuvant. We're going to move to non-clear cell RCC, 20% of all clear cell. With Dr. Albiges, who's done a lot of work, starting from us, remember, 10 years ago at Dana-Farber and taking it to Gustave-Roussy. Laurel?
Thank you very much, Toni. Well, first, I want to congratulate the organizers of this meeting. It's always a great pleasure and fantastic to see this crowd around such nice research. And 10 years ago, actually, my first work with Toni was about the obesity paradox. So I was glad to have this morning highlight as well. So moving on to non-clear cell, I think I owe to yesterday's amazing pathological session the fact that I will not be presenting pooled non-clear cell data. And I'm going to try to present what are the most recent updates based on the different subtype for which we have data. So we heard yesterday that we have this, let's say, long classification, but the good news is that we have more and more specific information on the results to systemic therapy for different entities. So the most common one being papillary RCC. And the good news is that papillary really changed the game because it was the first one for which we had proper single agent prospective data at the time, sunitinib, everolimus, axitinib, but also randomized data. And so you know that cabozantinib came in our guidelines as the favored option based on the PAPMED study. Since that time, we've received different results with combination. The caveat of my presentation is that I'm going to go into little numbers of patients. If you pay attention to cabo-atezo, vev-atezo, these are small numbers of patients. So it's not easy to draw any definite conclusion. I believe that the most recent update that we've heard, both on the Cabo-Nivo updated data, as well as the Len-PEM subgroup analysis within B61, is clearly highlighting what we've been able to achieve when getting to combination therapy for papillary RCC. Response rate in the range of 50%. Every other patient will have achieved significant tumor shrinkage. Median PFS, single agent TKI, you may remember, was somewhere around 6-8 months, now outreaching the year and a half. So clearly we made a difference. The second thing is that for the first time, in terms of overall survival, we are also seeing a difference. About 10 years ago, when IMDC was looking at the prognosis of patients with papillary, the median overall survival was in the range of 1 year, 1 year and a half. Now, we've been able to change the game, because if you pay attention to the lenvatinib plus pembrolizumab data, at the 18 months mark, we have an overall survival rate that is above 70%. So I really believe that despite the fact that this is not randomized data, we have a strong body of evidence on those combination studies that we have been able to push the bar for papillary RCC. That was the all-comers papillary. The second good news around papillary is that we have been making progress in defining biomarker-based strategy. And Toni paved the way with the so-called MET-driven approach, which is basically patients that will have an activation of the MET pathway, either through amplification or chromosome 7 gain, or even the mutation on the kinase domain of MET. The thing is, it takes a village to conduct such trials, because you are picking biomarker-driven within a not so frequent entity. So there has been randomized data, and the SAVOIR trial randomized 60 patients. There has been also the durvalumab plus savolitinib led by Christian Suarez and Tom, which here again identified patients that had a MET-driven tumors and seems to derive benefit of MET-specific inhibitor savolitinib in combination there with durvalumab. I'm going to move away from papillary before I get into the next trials to talk about chromophobe RCC. The numbers are getting even smaller. It's hard to decide on a patient treatment strategy when you have less than 10 patients cohorts being reported. Nevertheless, combination therapy, here either with lenvatinib everolimus or lenvatinib pembrolizumab, are the one that seems to derive the higher benefit. Why is that? Because the response rates are above what we've seen with single agent, especially in the past pembrolizumab single aid. So with lenvatinib pembrolizumab, we had about 29 patients in this trial with chromophobe RCC. Response rate was 34.5%, and the median PFS around 2 years in this subset. At this ASCO, we heard from the Memorial Group this very interesting retrospective analysis looking at patients with chromophobe RCC. First, this is a summary of the data that had been generated before, but what the team was able to do was to pull together, and it's a multi-institution effort, 102 patients with metastatic chromophobe. So of course there is a bias because these are patients treated over time, so you have more TKI single agents that was available in the past. But the bottom line is that it's very likely that for chromophobe, single agent may not be the major results, and we want to work towards a combination. And will it be lenvatinib-based combination such as Len-Ev or Len-PEM? Can we have new players? I think there is a need for chromophobe RCC to do a better job. Now, with regard to translocation, here again, small numbers, and we heard yesterday that it's not one entity. It is actually different fusion, even amplification that we can have there. Cabozantinib single agent data was a retrospective effort conducted multi-institution, response rate 17%, PFS 8 months, median overall survival 17 months. So not such of a response. We've heard more recently, here again with a good collaboration between the US and France actually, and Europe, that combination seems to play a role in this subset. IO, TKI, look at the response rate. IO TKI seems to derive higher benefit, 30%. And so we are getting into a better understanding of the biology. IO-TKIs, including the lenvatinib pembrolizumab data, seems to be the one that had the highest response rate in the range of 25%. We need to generate more data for this specific patient population, but I urge you to treat them with combination approach. FH deficient RCC. Not much prospective data since last KCRS. Erlotinib bevacizumab has been developed here in the US. A nice response rate in those patients that have FH deficient RCC. There is actually a prospective study now testing triplets with the addition of bevacizumab and atezolizumab on top. But we have in our group generated real-world data, and the good news is that thanks to the access of new agents, the median overall survival of this patient is now reaching the 40 months mark. RMC was one of the discussions we had yesterday. I want to thank Monty for sharing this slide from his excellent ASCO educational presentation. Obviously, Dr. Motzer has really paved the way in how we should think about those patients, accessing them to clinical trial, generating prospective data. We are treating them with platinum-based chemotherapy, and there is more and more work, especially here in the US. I believe it's great that patients get access to tertiary centers and clinical trials. And moving on to collecting duct carcinoma, I want to share these trials with you because it was a huge effort. We actually had a prospective trial in French for collecting duct carcinoma. It took us 4 years, 18 centers to enroll 34 patients. It was built on the fact that Stéphane Houdard in the past had generated data retrospective on chemotherapy, and here was the addition of bevacizumab. And so to put a long story short, the study did not meet the predefined endpoints that addition of bev would actually increase both the progression-free survival and the overall survival. So today, there is no added value of a VEGF targeting strategy on top of your combination chemotherapy. Now I'm going to finish on unclassified RCC. I believe we have less and less these diagnoses because our pathologists are doing a great job to decipher what entity they're facing, but this can happen. And in this case, how should we treat those patients? And these are very little numbers, but in the lenvatinib pembrolizumab study, we also had some of these patients. I think we want to make sure they get access to at least 2 different classes of drug, one potent VEGF-TKI plus one PD-1 inhibitor. What are the remaining gaps? There are pending trials, 2 of which are enrolling non-clear cell RCC, but big enough to answer in the different subgroup as I've just shown you in the other studies. And so one will be about nivolumab, ipilimumab versus standard of care. We are waiting to have these results coming shortly. The STELLAR 304 study led by Monty is a very important study as well as it's a randomized study. What about specific papillary RCC? We have PAPMED2 study. I'm glad this is up and running. It will help to define the contribution of the component. We have, that's another, there is a typo here, the PAXIPEM study as well as the SAMETA biomarker-based strategy. What are the remaining gaps? Although we have those pending trials, I think we need more information about the adjuvant strategy. Only the V94004 study enrolled papillary RCC, but the other subset are not enrolled. How should we treat patients beyond IO-TKI? I have not shown you second-line data because we don't have these. And there's many questions overall around the strategy that we should have with regard to treating the primary in those patients. With that, I would like to thank you for your attention.
Great, thank you. And now we're going to move into novel therapies. Many of these therapies are not FDA ruled, and we got to group this by non-immunotherapy versus immunotherapy. Dr. McKay is going to attack the novel therapy outside immunotherapy.
Thank you, Toni. I always love putting together this talk because I get to go through all of the meetings that happened over the last year from AACR, GU, ASCO, and others, kind of thinking about what's new in the field and so forth. So here are my disclosures, and just to give us an overview of the different things that we're going to be talking about. So anti-angiogenics continue to be paradigm shifting in RCC. And as the talk has evolved, it was VEGF targeting, and now we've shifted to anti-angiogenics because we're including HIP inhibitors in there as well. Selective drugs, specifically talking about conjugated therapies. I think we'll spend some time discussing the different sorts of targeted conjugated therapies that are out there and where the field is right now with regards to that, and then talk about other targets, some of which were highlighted within the trials in progress session yesterday. So starting with the anti-angiogenics, the HIF-VEGF pathway continues to be an ever important pathway with regards to RCC. We've already heard a little bit about Zanza from Dr. Motzer. Inhibits it's a basically multi-targeted inhibitor of receptor tyrosine kinases. VEGF inhibition affects TAM kinases. It reduces tumor angiogenesis, impedes tumor growth, and actually relieves that immunosuppression that happens within the tumor microenvironment. Monty had presented some really excellent work from Stellar 001 at ASCO this year, demonstrating a response rate of 38% with this agent in a treatment refractory setting. 97% of patients had received a prior checkpoint inhibitor, 81 had received a prior TKI, and looking at a median number of lines of therapy around 2. What was also demonstrated is that there seemed to be modulation of basically plasma biomarkers that were significantly associated with response to Zanza. The numbers are not very high, but we can sort of begin to see a signal around some of the plasma biomarkers that were looked at, IL-6 and others. Additionally, there was a evaluation of the immune cell subsets that seemed to significantly change following Zanza treatment, specifically around suppression of MDSCs that were seen on treatment. There's many trials that are currently ongoing looking at combinations of Zanza. Stellar 001 has closed enrollment. Stellar 002 is looking at Zanza in combination with Nivo and Nivo-Ipi. That study is continuing to enroll patients with a primary completion date on clinicaltrials.gov of 2026, though hopefully we'll see data evolve from that study. And then Stellar 009 is looking at Excel 092 with AB521, which we'll talk about, is a HIF inhibitor, HIF2 alpha inhibitor with Arcus. And then the combination with nivolumab as well. And this is not just a RCC specific study, but also looking at other solid tumors. That trial is currently ongoing. Bob alluded to sort of the differences from Zanza with cabozantinib that seems to have a shorter half-life, better PK properties, better tolerability. But hopefully we can also begin to dissect if there's mechanistically anything different between these two agents. Now let's talk about combinations. We saw data about the combination of belzutifan with cabozantinib. This data is kind of beyond the year, but recently published in Lancet from the phase 2 multicenter open label study, LightSpark 003. This is data from cohort 2. Cohort 2 was patients that were previously pretreated. We see an objective response rate of 30.8% here. 52 patients, 54 had received prior IO, 46 prior IO VEGF. But, I think the PFS is respectable here, 13.8 months. But I think kind of level setting of where the high benchmark is for Cabo in the second line setting from Contact 03 with a response rate of 40% and a PFS, right around the 10-month mark. So I think it's going to be interesting to see sort of what the addition of a HIF2 alpha inhibitor does to the backbone of a VEGF inhibitor. We're going to talk about that in a little bit. There was also data that were presented in the treatment naive cohort as well. This was actually ESMO from 2022, demonstrating really substantial response rate of 57%, zero PD rate in this context, keeping in mind that 60% of these patients had favorable risk disease. But I think this data really were quite provocative, and you can see the spider plots here of the reduction of the curves, PFS of 30.3 months. So I think it's really interesting and very provocative about the earlier use of belzutifan. There's a lot of discussion about utilizing HIF2 alpha inhibition earlier when the tumor is more addicted to that pathway and hasn't developed resistant mechanisms. We've heard a little bit about the belzutifan-lenvatinib combination. This is data from the phase 1/2 Keymaker U03 study that were presented, demonstrating a response rate of 50% with a primary PD rate of 4% with the combination of belzutifan with lenvatinib. And, this kind of is led the way into various belzutifan combination trials, many of which have been alluded to across all the talks this morning. 011, looking at the combination of lenvatinib belzutifan compared to Cabo, with a primary completion date at the end of this year. We're all eagerly awaiting the results of the study. LIGHTSPARK-012, which is looking at triplets in the frontline setting built on the backbone of lenvatinib pembrolizumab. So I think this trial will also be informative. It's this and Pedigree, I think, are the two frontline studies that may maybe have a little anthill on that plateau that Tom talked about. And then LIGHTSPARK-022 is the adjuvant study that Brad discussed of belzutifan pembrolizumab, currently closed and awaiting completion in 2026. Bob touched on DFF332. This is a small molecule inhibitor of HIF-2 alpha. Monty had presented this data at ASCO this year. I think we were underwhelmed, with the responses that we're seeing. There was two responses that were observed, objective response rate of 5%. The bulk of these patients were very heavily pretreated. 50% of patients had received 3 or more prior lines of therapy. Thinking about the kinetics of this agent, really long half-life of 85 days, fast oral absorption, but there was no DLTs related to hypoxia. Baseline HIT levels did not really correlate with response. There was, it's hard to correlate anything with response when your response rate is 5%. So I think what we don't know, we're going to kind of get to this a little bit, is we're seeing a lot of these HIF-2 alpha inhibitors now that are in development. What is the discriminating factor around these agents? Like, how are they different? Are they mechanistically different? How are they different from a pharmacokinetic standpoint? We don't yet have any data around that. I think we're all curious to understand what are the differences. I've chatted a little bit about AB521. This is Arcus, small molecule oral HIF-2 alpha inhibitor. Stay tuned for the biotech showcase at the end of the day. Don't leave. We're really excited about the biotech showcase this year, so I got to give it a plug. There will be some data that will be presented of the HIF-2 alpha program with Arcus, and the first in human study is still continuing to enroll patients, and I told you about Stellar 009 as well. Yet another HIF-2 alpha inhibitor, potent selective oral agent, the NiKang 2152 agent, selectively suppresses HIF-2 alpha gene expression, has a favorable PK profile. I think we'll have to see sort of what happens with this agent over time. This is the preclinical data that's demonstrated on this curve. There's currently a phase 2 study of NKT2152 with palbo and sanzilizumab for patients with advanced RCC. And that kind of segues us now kind of moving a little bit away from the anti-angiogenics. I tried to cut out a slide of transition, but now we're going to talk a little bit about palbociclib. I think we're all eager to see what is the clinical role of CDK4/6 inhibition in kidney cancer. Selective inhibitor, so palbociclib, selective inhibitor of CDK4/6. And want to highlight the first time we're actually going to see data from Brad later this afternoon, oral abstract session. So it's really exciting that we're seeing first time ever presented data of the triplet of avulimab, axitinib plus palbociclib, 25 patients, primary endpoint, objective response. And then the LIGHTSPARK-024 study is a phase 1/2 multi-center randomized trial that's looking at the combination of palbo with belzutifan. We chatted a little bit about HC7366. I think this is a very novel agent with a very novel mechanism of action. Definitely trying to sort of dissect this pathway. So in essence, GCN2 is a metabolic stress sensor. It senses amino acid deprivation. And when it senses amino acid deprivation related to stress induced by a tumor, it actually can decrease transcription and ultimately lead to cellular apoptosis. And so HC7366 is an activator of GCN2, but it also seems to have other multifaceted mechanisms of action with regards to downregulation of HIF and modulating the tumor microenvironment. there is a currently enrolling study in combination with belzutifan and RCC. All right, now we're shifting to selective drug conjugates. There's been a lot that's out there. I'm going to try to speed through some of these trials because I think they've all been really underwhelming, even though we're all super excited about these therapies and they're making big splashes in other diseases, but they just haven't hit the mark in kidney cancer. So there's different carriers from peptides to antibodies, small molecules, different linkers, cleavable, non-cleavable, and different payloads. So it's like, what's the target, linking it, and then, the payload, whether it be chemotherapy or a radioligand. So here's sort of like all of the targets that I could sort of find kind of within the literature that have been attempted to be targeted with such therapies. We won't go through this. These are the different agents from radioligands to ADCs, essentially, different sort of monoclonal ADCs. And really the take-home message is that the activity has been very, very limited across all of these agents. There's not a lot of studies. There's not a lot of patients. The tox is not great. And so I think we need to do better. I think there's potential, but we're just not quite there with these data. And so the rationale for limited activity is on-target, off-tumor effects, heterogeneity of target expression within the tumor. Is the drug even being taken up in the tumor? What about circulating molecular decoys, properties of the linker and dissociation there? And then the sensitivity of the tumor to the payload. We don't treat kidney cancer with chemotherapy. So, I think we need to sort of understand how we can overcome these barriers. So I'm going to skip the conclusions, but I'm always high. The third sort.
Excellent. Finally, Dr. David Braun, my dear friend and mentee now at Yale, formerly at Dana-Farber, who's been in Eddie's lab and now runs his own group at Yale, still having a very, very close partnership with us. David?
Well, thank you so much for the opportunity to speak and for sticking with me through, I think, next is break. So hopefully this will go relatively quickly. So these are my disclosures. I'm tasked with talking about all of novel immunotherapy strategies, which is a little bit hard for 10 minutes. And so I'm going to use a framework, one that I introduced at ASCO, on how to think about these different categories of immunotherapy. And we're not going to dive into every single one. We'll give kind of conceptually what are the different buckets and then some good examples of things that are in development. And the framework I'm going to use is largely adapted from Patrick Ott and Kathy Wu, one of my former mentors. And it's simplified, but I think it's actually pretty effective. It's the idea of the immune system as a car, and you're trying to drive that car towards the tumor. And how do you get there? How do you get there quickly? And how do you get there accurate? And so what are the levers we can pull on in order to really effectively drive anti-tumor immunity? So we can release the brakes. That's where current immune checkpoint inhibitors lie. That's the bulk of our current therapies. We can press on the gas pedals. That's historically with cytokine therapies, and we'll talk about newer agents, novel sort of engineered cytokine approaches. Both of those things make the car move more quickly, but none of those things actually steer the car toward the tumor. And so to give it some directionality, that's where we can think about antigen-directed therapies, and we'll talk about a few approaches there as well. And then finally, I'll just very briefly touch on, you can have all the things go right, but if you're stuck in traffic, the car's not going to go very far. So how do we clear the traffic out of the way, really modulate T-cell extrinsic back? And so we'll quickly jump through each of these one by one. So the first is releasing the brakes. And this is really the classic immune checkpoint inhibitors. And right now, that really just consists of targeting the PD-1 pathway and targeting the CTLA-4 pathway. And if we look at the current landscape of systemic therapies, you can see it's really dominated, particularly in the first-line setting, by IO-based therapies. Just about every patient should receive an IO-based combination. So what is sort of the next generation? And I think we've been waiting for a long time for more checkpoints. And I think there's a lot of excitement, but there's a lot of development work that needs to be done. So one in particular that I want to highlight is HPK1. This is early in development, and HPK1 essentially acts as a checkpoint to attenuate TCR signaling, but actually acts also on B cells and dendritic cells. It inhibits dendritic cell maturation and antigen presentation, as well as B cell activity. So this is a compound that's relatively new to the clinic, but in the dose escalation, there were a couple of RCC patients that were treated. And while it's just 2 patients, those two patients, one had a complete response and one had a stable disease that was fairly durable. And so I think something that is, as it goes towards dose expansion, something to keep an eye out for. There's lots of other targets that are being investigated. TIGIT, LAG3, I think there's a lot of excitement about. And then pathways that we don't think about necessarily as much, but based on the work from Ford and Freeman, it's targeting the HHLA2 tier 3DL3 pathway. And there's actually in phase 1 clinical trials now, 2 antibodies, one targeting HHLA2, one targeting the inhibitory receptor tier 3DL3. And then we heard from Mike Serzan earlier about improving on our classic anti-PD-1 anti-CTLA4 strategy. This is the Architect trial led by Mike Serzan and Mike Atkins. And I think really the idea of enhancing that CTLA4 blockade, potentially depleting Tregs, could be a really nice. So that's releasing the brakes. What about pressing on the gas pedal? And to understand why this is, I think, an appealing approach, it's worth going back in time a little bit to a brief history of systemic therapies in kidney cancer, which really started with cytokine therapies. When you had the molecularly targeted era, we have our current checkpoint era, but the cytokine therapy had its successes. If we look at high-dose IL-2, complete responses were rare and there were lots of toxicities, but some of those complete responses were really remarkable. The durability of those responses are perhaps unparalleled. So can we learn lessons of what went well in cytokine therapy, but potentially improve upon it? And I think one of the ideas is that high-dose IL-2 can really activate CD8 T cells, and that's something that we want, but it can also drive NK cell proliferation, and might be helpful, but can also drive toxicity. But it also drives Treg growth, and that can be immunosuppressing. And so maybe rather than giving a lot of IL-2, maybe we can steer the IL-2 to where we want it to go. And one of those approaches is doing exactly that. It's conjugating IL-2 to an anti-CD8 molecule, so-called cis-targeting IL-2 approaches. And this is from Asher Bio. And by delivering IL-2 directly to CD8 T cells, this is in non-human primate studies, you can see a rapid expansion of CD8 T cells with really modest to little effect on NK cells and Tregs. And so this is something that's in phase 1 trials now, but it's not the only approach. I want to highlight there's other really exciting approaches as well, such as targeting the dimeric alpha-beta IL-2 receptor that Synthokyne is doing, and we'll hear about that more later in the afternoon at the Biotech Showcase. But IL-2 is not the only cytokine that we can target. There's lots of others that have potential anti-tumor activity, one of those being IL-18. IL-18 is really highly expressed, as well as its constituents, its receptor and binding protein in clear cell RCC. This is work really in the clear cell field that's being led by David Schoenfeld at Yale, who's done really remarkable preclinical and bringing it to clinical work. And so IL-18 has been really appealing, but in the clinic, it's largely fallen flat. And a big part of that is because it has an inhibitory, basically protein, the IL-18 BP, which basically binds up and inhibits any IL-18 we would deliver. And so with clever engineering from Aaron Ring, he developed a decoy-resistant form of IL-18 that in preclinical models has really dramatic effects. And this is now in phase 1 trials, including in RCC, ST067 from Simpat Therapeutics. So again, we have released the brakes, we have pressing up the gas pedal, but how can we actually steer the immune system for where we want to go? And this is really where antigen-directed therapies come into play. And there's lots of different ways of giving an antigen-directed therapy. And so how I sort of think about it is largely along 2 axes. One is, what are you targeting? Are you targeting something on the cell surface? That's the first column. Or are you targeting something that's HLA restricted, presented on something that's intracellular, that's been presented on HLA class 1 models? And that's the second column. And then finally, do you have to have a personalized therapy, or is it something that's available off the shelf? And with this kind of 2x2 axis, we can fill in a lot of our therapies. Classic CAR T cells that target surface antigens and are personalized. Allogeneic CAR T cells and T cell engagers that target surface antigens but to be delivered off the shelf. Targeting HLA-restricted antigens either through shared cancer vaccines, which have not been as successful in the past, or more excitingly, I think, with personalized neoantigen vaccines, as we started to hear about here today. So to briefly highlight a couple of the strategies that are in development, the first is really targeting surface epitopes with an off-the-shelf approach, and that's with allogeneic CAR T cells. And there have been 2 that have been reported so far. First from Monty Paul, and this was the CTX130 trial that we saw. And, there weren't a huge number of responses, but I think as a proof of concept, there was one complete response ongoing for 3 years And the idea that a CAR T cell could control a solid tumor is actually really exciting. And if we look at data from Traverse, from Allogene's product, we see now the response rates increase. And we see that the overall response rate being around 17%. But if we look at patients that had CD70 positive tumors, we see actually a 30% response rate, though the numbers are very small. And so I think thinking about cellular therapies targeting surface antigens is a really appealing strategy that we're going to see develop. But it doesn't just have to be a cell therapy. There's also drugs that can do this, particularly T-cell engager strategies. And so this is one example from Xencor, and we'll hear from Chet and Xencor again during the biotech showcase. But this is the idea of bringing in and activating T-cells with a tumor target. In this case, ENPP3, which is widely expressed on clear cell RCC, and dragging in CD3 positive lesions. So that's targeting surface antigens. What about targeting HLA-restricted antigens? And we've heard a lot about neoantigen vaccines. And so I'll just quickly review that the phase 1 trial was peptide-based, not mRNA-based, but it really created a personalized approach. So each individual patient would have their tumor sequence, the most predicted immunogenic epitopes were selected and manufactured, and then delivered as an adjuvant vaccine. And I won't go over the results except to say kidney cancer is not melanoma. There's not hundreds upon hundreds of mutations. So really the first question we had was, just can we do this? Do we have enough mutations to successfully vaccinate patients? And for the first 9 patients, we can see that for every single one of those patients, even though their mutation burden was very modest, we could successfully vaccinate them with many, many different epitopes, often with single nucleotide variant encoded peptides and frame shift insertion deletions, and in many cases, target key driver mutations within kidney cancer. And then we've heard a lot about the B940-004 trial, which is now enrolling. And then very brief in the last few seconds, how can we clear the traffic? So we talked a lot about T cells and really a T cell heavy focus. So in this morning's keynote, we heard about the myeloid compartment and how important that is. So there's many other components of a successful immune response, including targeting immune suppressive cells, but also having a sort of favorable overall immune milieu. And part of that is having a favorable microbiome. And so in work led by Monty Paul, Nazli Diesman, and others, we've seen some early successes of CDM588, this live bacterial product containing the spore-forming bacteria Clostridium eutyricum. And when this was added either to Nivo-Ipi on the left or to Nivo-Cabo on the right, we can see that the clinical outcomes were overall superior. Now we have to caution, these are small trials. There's only 20 patients in the experimental compared to 10 patients in the control arm. But I think it actually sets up some excitement that potentially modifying the microbiome can really improve the immune milieu that might lead to successful therapies. So overall, we know that now immune therapy really forms the backbone of advanced clear cell kidney cancer. And when we think forward of how to develop new strategies, I think we can think along these 4 axes, and that should help guide us a little bit on how to think about current therapies and future ones. And thank you so much, everyone, for participating in the trials, the KCRS organizers, and have a day with us. Thank you.
I mean, this is hopefully, we showed you a glimpse of what's happening in RCC in terms of clinical and translational work, mostly clinically applied, clinical application, but at least the last 2 talks for all the patient and the patient advocate in the room that our target, unlike what Dr. Powles started initially with PD-1, VEGF, and maybe HIF-2, and gave us this perhaps less positive picture about the future. Actually, the future in the last 2 talks, Tom, and that's why I'm taking the side of Spain, I guess, England on Sunday, and Euros. The last 2 talks, you saw that plethora of not just target, but of drugs, both immunotherapy and non-immunotherapy. So thank you. So we're going to take some questions from the audience, but I'm going to do the opposite by taking first, in online and then from the audience. So I'm going to start actually by Dr. Motzer. Bob, are you giving Ipi-Nivo for favor risk following this 8-year 214 presentation by Dr. Tani? Did your clinic practice change?
So, I mean, I have to say that for me, the therapy that I favor for favorable risk is TKI-IO. And so I usually give those patients lenvatinib pembrolizumab. And I'm aware of the data with ipi-nivo, and obviously I've been involved in involvement, but my initial experience with giving ipi-nivo to the favorable risk patients is I saw the response rate very low, and in the setting of IO-related toxicity, it made me concerned. I also think that although the survival is the same, the patients do, since the response rate is low, they do relapse on ipi-nivo, and I think it's traumatic for patients to relapse or progress and need to change therapy. So recognizing that this is definitely an option that I discuss with patients, for the most part, I favor the TKI-IO combination.
What about you, Dr. McKay?
I tend to like giving patients nivo ipi. I tend to be in the nivo ipi camp unless I need to think of a reason to not give them. These patients do well, they're asymptomatic, they have to see second-line therapy. I think the data from the 8-year follow-up, I was really provocative about the potential long-term benefits. But I think what's happening in the beginning course of the recurrent, we can't really underestimate that. So, but it has shifted.
Anyone want to take Dr. Motzer camp here with IOTKI on the panel here? I know this is a very inclusive meeting. We don't want to feel Dr. Motzer exclude anyone from anyone.
Look, I said what I said before. I think favorable risk concept needs to you need to move on from. If you want to give these patients ipi-nivo, someone sure will respond very well. Early so long considering current environment. Really the strongest data currently for a response PFS perspective and the OS perspective is historically, but on now as the VEGF TKI-IO. Point I would make, which I'm kind of beginning to change my mind about, is I don't think single agent VEGF TKI is that attractive for these patients. Although the data is not unsupportive from a survival perspective, I think getting immunotherapy up front patient.
I mean, to me, I would say the only advantage is perhaps, of course, the long-term remission, but getting ipi there. Because if you don't get ipi at first line, I'm likely to get it later. But once the disease burden is medium to high, I try to avoid nivo ipi because not every patient can get second-line therapy. So I'm more towards Barts camp. Now we're going to open the question to the audience. I don't see anyone. Nizar, next. Nizar, just throw it, Mike. Mike, you have a good hand.
Great session. Actually, it's not a question. I think it's a comment, which I think deals with David's talk at the end about immunotherapy. I think an important field for patients and caregivers in oncology is in general, and we've learned about this. We keep telling our patients stress, depression are bad for immune system, and an interesting study that just was published in Nature Medicine from China, not in kidney cancer, but in non-small cell lung cancer, treated with immune checkpoint therapy plus or minus chemotherapy. Patients who had a high score of ED, and that's emotional distress, not the other thing you're thinking about, Tony.
Yeah, but on stage, you do that to me. I mean, come on.
It's patients who had high emotional distress score at baseline prior to initiation of systemic therapy for non-small cell lung cancer had a worse outcome to therapy with lower ORR, shorter PFS, and inferior survival compared to patients who had low emotional distress score, underscoring the importance of managing mental health in patients with cancer in general. And I do think a study in RCC, clear cell, I would say you could say nivo ipi plus, and look at patients and manage, intervene, and those who had high emotional distress score, treat them with anxiolytics if they have high anxiety level, antidepressants if they have depression. I think this is really relevant for the field and for patients.
Before I give it to Hans, I don't know if you can throw it to Monty. Monty has worked and mentored Dr. Bergeron now in Brazil, who's doing that kind of work, evolving from PRO and quality of life to mindfulness, mental health. Monty,
delivering the baby in person.
There's no quarterbacking, I guess. Okay.
Yeah, it's not so much, my work, as you mentioned, Tony, as it is Chris's, but Chris is a terrific psychologist. Many of us in the room worked with her. And over the years, she's developed a number of strategies. The one that immediately comes to mind is a phone-based mindfulness tool that really seems to mitigate stress levels, can sort of ease the burden of anxiety associated with cancer. And, I really do think that, those are some of the things that we can work on as an adjunct to developing all these new systemic therapies. Thanks, Drew.
Thank you.
Hans?
Great. Well, first of all, a comment to Tom. I'm glad to see you coming over to the NIVO-IP side of things.
And sounds like it. Congratulations.
I have two questions. Number one is, you and Bob, when we talked about, let's say, in the post-adjuvant space of what to do next, right? We always say we challenge off immunotherapy, but we don't differentiate the types of immunotherapy, right? So obviously, we challenge with PD-1 to me makes zero sense. But the question is, what about NIVO-IP in that space, right? So response rates 10-15% in patients who had prior PD-1 progression across 3 independent trials. Single agent ipilimumab activity 10-15%. So I think there is some activity there, and I would say, pointing out to Dr. Surzin and Mike Atkins. We should be more specific. Would love to hear your comments on that. The other one is on the adjuvant therapy. I do think, when we talk about the subsequent therapies, we always say the 70%, it's actually not the real number. The exposure of immunotherapy in the placebo group after progression is 48%. Yes, some patients were treated with focal therapy, etc. We mix it in, but I do think there is a real question in my book that we need to get answer on if there was potentially an access issue across the world. If you were a patient on the placebo in Russia, it's very unlikely you're ever going to see immunotherapy. So I do think we need some more data. I have not seen the data yet to quell my concern that we are rubber stamping an OS benefit that may not be real. I hope it's real, but I do want to see the data, and it's not difficult to get the data to quell some of the concerns that I have.
Yeah, just in answer to that, we have looked and we have an editorial that kind of comments about, with time. The use with immunotherapy with time, depending how you censor, is increasing. But I would counter back and say there are patients with first-line metastatic RCC, first-line, that do not get therapy. In the U.S., the unofficial number, actually located from Medicare database everywhere, is around 20%, 15-20% do not come up. So the question here, perhaps you should give adjuvant immunotherapy because you're not getting into therapy in the first-line metastatic setting, because I could not imagine at that time, unproven, now definitely proven therapy where you definitely should cross over, for example.
Yeah. I mean, the issue is a little bit, it's because of trial design, it's very difficult to say, okay, some people were treated like this, is that, etc. I think the number to look at that we and others have raised is of the patients who died on the placebo arm. The patients who were really in trouble. How many of those patients actually got immunotherapy, yes or no? In my practice in the United States, it would have been 90+% for sure. And I think that's a very easy number to get. And if the number is high, I will be silent. But I do think it's a number that we take a look at. The other question that I have is, what about under treatment with pembrolizumab in the adjuvant space? So if I think about sarcomatoid, for example, if I think about M1, NED, for example, these are patients that I would have treated with dual immune checkpoints, for example. What are the thoughts in the panel about potential under treatment for some of those patients?
Under treatment, anyone here, you want to take that? David, you haven't talked. Would you give NIVO-IP and sarcomatoid high risk despite Bob's negative study?
Yeah, and I will say the post-hoc analysis, I think, for something that action is a late table for NIVO-IP, but in general, I would still give access after, but I understand the risk. I think it goes back to the idea that you only have one shot therapy, and you give them away that shot by just using the single agent anti-PD-1. I'm probably in your camp that I think CTLA-4 is a different mode. So even after progression on adjuvant pembro, it's not that I would never use NIVO-IP. So I don't feel like I've excluded that possibility in turn, and for that reason, I maybe am a little bit less concerned about the end.
So we're going to have
just say, in terms of his point, I mean, the other is the M1 NED group, right? So, I mean, I've had patients who've had sarcomatoid RCC, and then they have a nodule in their lung, which we remove in this sarcomatoid RCC. So, I mean, for that patient, I actually gave a Vivi-Vivo because of the sarcomatoid component. This is M1 NED. I really felt that patient needed 2 drugs rather than Pembo. But I don't know. I mean, is that the same sort of thought you follow? What do you think about that? That's a different group, I think, than the localized. That I would think giving 2 drugs.
Bob, I totally agree with you. In my book, to be honest with you, in my book, the M1 NED should have never existed as a group because they have metastatic disease. They need systemic therapy. Anyways, if anything, the data set generated with KEYNOTE-564 suggests we should not do surgery first and then do monotherapy afterwards. Because you need immunotherapy anyways. So if you have metastatic disease, why not treating with it? Plus, the patients, at least on KEYNOTE-564, were in the first year. By definition, there's intermediate risk disease at minimum. And those patients, take it out and then treat with just one immunotherapy drug, at least for the people who are on the dual immune checkpoint camps, is difficult to accept.
Well, maybe, but M1 NED surgery only still cured 25% of patients. Let me go and make Dr. Gordon Freeman here. Thank you, Gordon, for always attending even the first, KCRS. He has a question, Gordon.
Following up on the emotional distress and depression, poor influence on immunotherapy response. Lily Yang at UCLA has shown that the monoamine oxidase antidepressants have an immunological mechanism and can synergize with PD-1 in mouse models. It would seem like that might be an antidepressant to pursue, and also analyze clinical data to see if any patients receiving monoamine oxidase drugs have better or worse responses.
It is a great insight, the type of drugs that work on emotional distress. Monty?
Yeah, fantastic talks all around. Toni, you and I had had this conversation before in the sense that, maybe the next big development in kidney cancer is hiding somewhere in a phase 1 clinical trial. And I reflect on some of the experiences I've had recently, the DFF 332 experience, for instance. I just feel like we could have done better. I know I talked to Nizar, Laurence, all my co-investigators on that study. We had a very, very conservative dose escalation schedule. We saw the data for belzutifan coming. We probably could have accelerated that to some extent. We didn't get nearly to doses that we felt were really sufficient to demonstrate activity. So there's that component of, maybe how we could have improved on that phase 1. I'm also a little bit worried about the fate of, forthcoming phase 1s because we're seeing lots of patients on these studies that are in the 7th and 8th line setting, for instance, at least at my institution. I can say the same for many of my colleagues. And I just wonder if we're treating the same disease. For instance, with CTX130, a CD70-directed CAR T, right? The data for CD70 expression is predicated on nephrectomy specimens. And one thing that we know now is that there's some diminution in expression over time, and I'm sure that's true for a lot of the antigen targeting approaches that we're taking. So I really wanted to get the sense from the panel as to whether or not you think it's okay to do something that I'm starting to do now, which is if I have a patient who's progressing on, for instance, Cabo-Nivo, they got into VEGF PD-1 in combination. I think that second line setting, maybe the third line setting as well, is appropriate for phase 1s. And I think that we might see better signals of activity if we start pushing some of these with a really, thoughtful phase 1s into earlier settings.
Yeah, so last answer I'm going to ask Dr. Albiges, and then we are going to have the break. So would you think, let's say progression after Cabo-Nivo or Pembrolizumab, 2 strong drugs, would you go into a phase 1 of a promising target so that you can get second, third line, not 8th line treatment? Would you feel comfortable doing that?
Yeah, the short answer is yes. I think I want my patient to get access to as many strategies they can. And if they can access to, innovative agents in earlier setting, I'm totally in. To Bob's point, I think belzutifan data in second line is also quite interesting. We'll be discussing that later today.
Thank you. Now the coffee break, 15 minutes. Please come back.